All right. Welcome to the Auditory Learner. This is going to be the Perio 2 study session for the quiz. I believe this is the third quiz that we're having. This is going to cover periodontitis and occlusion, furcation involvement, and endo considerations. So getting right into it, periodontal disease and occlusion. We need to make sure we understand the correlation between periodontal disease and occlusion. Injury to the periodontium results from excess occlusal forces of the reparative adaptive capacity. So although trauma from occlusion and inflammatory disease, a periodontal disease may occur concurrently. Each condition may be treated separately. In the presence of reduced periodontium, effects of occlusal traumatism may be magnified. So she gave the example of a bad fence. Okay. Occlusal trauma is any occlusion that produces periodontal injury is traumatic occlusion. Dentition may be anatomically and aesthetically acceptable, but functionally injurious. Not all malocclusions are necessarily injurious to the periodontium. When occlusal forces exceed the adaptive capacity, tissue injury occurs. This is when we go into primary and secondary occlusal trauma. This should be reviewed. Primary occlusal trauma is only one thing because it's primary, one thing. It's healthy periodontium, but the trauma from occlusion is a result of the alteration of occlusal forces. So healthy periodontium, but just a lot of grinding due to biting on things hard, high fillings, new appliances, or drifting. Primary occlusal trauma does not alter level of connective tissue attachment, does not initiate pocket formation. The supracrestal gingival fibers are not affected in primary occlusal trauma. The supracrestal gingival fibers are not affected, okay? Secondary occlusal trauma, on the other hand, okay, this is the reduced ability of tissues to resist the occlusal forces. Periodontal disease doesn't have to necessarily be active. It could be already on a reduced periodontium, but the adaptive capacities of tissues to withstand occlusal forces are impaired by bone loss and inflammation. So it reduces the periodontal attachment area. All right. So previously well-tolerated occlusal forces become traumatic and more vulnerable to injury. Systemic disorders can reduce tissue resistance. Okay. So again, there's a picture here for primary. You have normal bone, but it's starting to cause mobility. Secondary, you have already less bone to deal with. All right, and there's more mobility this time. Make sure we understand also the center of rotation. As perio progresses, the center of rotation moves apically. So for secondary occlusal trauma, the center of rotation is closer to the apices, as opposed to primary occlusal trauma, the center of rotation is more towards the middle of the tooth. Influence of trauma from occlusion. Trauma from occlusion does not cause pockets or diseases like gingivitis or periodontitis. When inflammation extends from the gingiva into the supporting periodontal tissues, that's when gingivitis becomes periodontitis. But then that's when we enter the zone influenced by occlusion. So there's things called zones of co-destruction. So zones of co-destruction, there's zone A and zone B. Zone A is zone of irritation, which is technically at where the CEJ is. And below the CEJ, or the cementum enamel junction, is the zone of co-destruction. All right, so zone of irritation is above the CEJ and zone of co-destruction is below. Okay, Destruction moves apically. More wiggle equals more bone loss. She used this analogy as like sand at the beach. Influence: when trauma from occlusion is eliminated, substantial reversal of bone loss can occur, except in the presence of periodontitis. And then when bone grows, it grows horizontally. It's important to eliminate marginal inflammation components such as plaque and pore restorations. But again, trauma from occlusion does not alter the inflammatory process. Trauma from occlusion does not alter the inflammatory process. She made sure to let us know that. Influence: trauma from occlusion changes the shape of alveolar crest. So what are things that can happen from trauma from occlusion? You get widening of the marginal PDL space, you get narrowing of interproximal alveolar bone, you get shelf-like thickening of the alveolar margin. So although it does not alter the inflammatory process, it can change the architecture of the area around the inflamed site, such as hypercementosis, tori, and exostoses. Influence, clinical influence: increased tooth mobility. Make sure there's plus 1, 2, 3. Increased tooth mobility is the most common sign. It cannot be considered pathologic. It becomes progressively worse. So again, plus is barely discernible, then 1, 2, 3. So the degree of tooth mobility, this is going to be an exam question. So there's two basic factors that determine the degree of tooth mobility. It's going to be the height of supporting tissues and widening of the PDLs. So those are the two factors of degrees of tooth mobility. Two basic factors that determine the degree of tooth mobility. It's going to be height of supporting tissues and widening of the PDL. All right, that's different from the mobilities that we were talking about before. These are the degrees, two factors that determine the degree. So these two factors determine whether you're a 1, 2, 3, or a plus. Well, that's good that we talked about that. The next thing is, how is mobility graded, right? So again, 0 is physiological mobility, 1, 2, 3. So plus, I would assume, is grade 0, which is called physiological mobility. Grade 1 mobility is slightly above normal, which is less than 1 millimeter buccolingually. Grade 2 mobility is above 1 millimeter buccolingually. And grade 3 mobility is 1 millimeter combined with displacement in the vertical direction, meaning that it can be depressed. So again, it's just like plus 1, 2, 3. Plus is barely discernible. 1 is less than 1 millimeter movement buccolingually. 2 is greater than 1 millimeter movement buccolingually. And 3 is greater than 1 millimeter movement buccolingually, but it's also depressed. So that should be pretty clear. Don't confuse that with the two factors that determine the degree of tooth mobility, which are height of supporting tissues and widening PDLs. We can see the influence radiographically, separation of PDLs, thickening of the lamina dura. So thickening of the lamina dura does not necessarily indicate destructive changes. It has to accompany other signs, but vertical destruction of the interdental septum, so the bone between the two teeth, the portion of the alveolar process extending between the roots of adjacent teeth, that will show radiograph influence. So radiolucency and condensation and root resorption. Those are all secondary trauma, okay? Again, physiological mobility is the natural occurrence of the movement, all right? It varies. It's the greatest in the morning. It's less likely in a healthy periodontium. It's greatest in the morning, but it's limited to occlusal contact during sleep and reduced by chewing and swallowing forces as the day progresses. Physiological mobility, again, more in more in those with occlusal habits, such as clenching, grinding, and chewing. These increase widening the PDLs. Single-rooted teeth have higher mobility in the horizontal direction. It can be axial, which means like twisting, but it's rare. The therapeutic goals for occlusion is to alleviate the factors. Several therapeutic objectives are elimination or reduction of tooth mobility, establish or maintain stable, reproducible intercuspal position, provide freedom of movement, develop comfortable occlusion, eliminate or modify parafunctional habits, establish occlusion with the acceptable phonation and aesthetic speak. So remove parafunctional habits such as pencil chewing or beer bottle opening. Also, prophylactic occlusal adjustments are contraindicated. Occlusal relationships may be evaluated as part of periodontal maintenance. So, scale it until the cows come home, but still, whatever that means. I don't know why I wrote that. She said scale until the cows come home. Outcome assessment. Desired outcome of treatment patient should be able to masticate comfortably. Results include, but not limited to, mobility should be either diminished or absent. Okay. So that was great for perio and occlusion. Let's talk about furcation involvement now. So furcation grades and classification. All right. So we determine furcations with the neighbor's probe. It's curved. We also determine it by radiographic evaluation, also clinical visibility, which means if it's seen without instrumentation. So a grade 1 is an incipient furcation. It's usually about 1 millimeter into the fossa. And that's, I remember now Professor Lawrence telling me that in the back of my head. Thank you, Professor Lawrence. All right, always check for furcations. The level of the bone allows for the insertion of the periodontal into the concavity or the fossa of the root trunk. At least 1 millimeter, okay? Grade 2 is 2 millimeters or greater. It may surpass half of the buccolingual thickness, but not through and through. If it's through and through, that we're gonna talk about that. But grade 2 is 2 millimeters or greater. Intraradicular bone attached to the angle of the furcation. Furcation defect is thus a cul-de-sac. So that means it kind of ends right there. All right. Bone remains attached to the tooth so that multiple areas of furcal bone loss, if present, do not communicate. This level of bone loss allows for the insertion of a periodontal probe into the furcation area between the roots. It's most likely visible, but not 100% of the time. It's most likely radiographically visible, but not always. That's a grade 2. Grade 3 now, the bone is no longer attached to the furcation of the tooth. All right, so grade 2, it's almost like the bone of the arch, wherever the level is, it's like right at the floor of the grade 2 millimeters. But grade 3, it's resulting in a through and through tunnel. So now the bone has dropped even more, allowing for the through and through. That's grade 3. The level of bone loss allows for a through and through access of the furcation area, buccal to lingual on lower molars, buccal to mesial palatal and distal palatal on upper molars. All right, so grade 3. That's going to be through and through, okay? Bone level is allowing for that. Grade 4 is the furcation opening is clinically visible. You don't even need to put a neighbor's probe in there. Essentially, it's like a super grade 3, they call it, but it's also grade 4. Make sure we know what the root trunk is, distance from the cement junction to the entrance of the furcation. That little space there, the root length, directly related to the quantity of attachment. Longer roots equal less mobility because longer roots are more readily treated. Interradicular dimensions, degree of separation of roots, close proximity of fused roots are harder to scale. We got interradicular dimensions. The first to have a furcation involvement is type B, the middle. The second to have type furcation involvement is type A, go to the left. And the third is type C, where the roots are very close by and it has a longer trunk. So for grade 1, you would need an SRP, removal of any overhangs. So objective of furcation therapy is to facilitate maintenance, prevent further attachment loss, and obliterate the furcation defects as a periodontal maintenance problem. Those are the three objectives for furcation therapy: facilitate maintenance, prevent further attachment loss, and obliterate furcation defects. Grade 1 requires an SRP, removal of overhangs, all right, usually sufficient. Grade 2 is going to require a localized flap procedure, odontoplasty or osteoplasty. Grade 3s are periodontal surgery, endodontic surgery, therapy, restorations may be required, usually do not respond to surgical treatment. Grade 4, clinically visible through and through. All right, so grade 1, SRP, grade 2, localized flap, grade 3 is perio surgery, endo surgery. Again, grade 1 is grade 1 is 1 millimeter into the fossa. Grade 2 is 2 millimeters or greater. And grade 3 is a through and through. And grade 4 is just you can see right through without even pointing anything inside. So again, we just talked about the interradicular dimensions. The first one to have a furcation is the B type, which is the middle one of this image. And then the second one is the A type, and the third one is the C type, which is the longer fused roots. What do you do with grade 1, SRPs and removal overhangs? Grade 2, localized flap procedures. Grade 3, perio surgery, endodontic therapies. You can have a root resection for grade 2s to 4 for vital or non-vital. Non-vital preferred prior to resection, so you might have to do a root canal prior to amputating the root. And sometimes you can do what's called a hemisection, splitting of a two-rooted tooth into one separate portion. Surgical therapy, grafting, you would hope for the best. Reconstruction, you can take tooth out too as well. Also, make sure you don't, make sure you check for enamel pearls. Cervical enamel projections are not enamel pearls. 8.6 to 28.6 of molars have highest in the mandible and maxillary. Second molars have a cervical enamel projections. Affect plaque removal, complicate SRPs, local factor, remove to facilitate maintenance. Cervical enamel projection. So a cervical enamel projection is not an enamel pearl. It's an ectopic extension of enamel that extends beyond the normal contours of the CEJ and extends into the furcation. An enamel pearl is a long, large, round projection of enamel located in furcations and other areas. A cervical enamel projection looks like something's dripping almost into the furcation fossa, whereas opposed to an enamel pearl, it looks like nothing's really dripping. It's just something was just placed there. If you can imagine that. All right, let's finish up with the endodontic considerations. All right, periodontal versus pulpal. A clear-cut relationship between periodontitis and pulpal involvement is not entirely evident. So what we need to know is retrograde pulpitis, meaning like the perio disease is the attacker. The victim is the victim. Perio disease is the attacker on retrograde pulpitis. Bacteria and inflammatory products of the periodontitis can gain access to the pulp of the accessory canals and the foramina and the dentinal tubules. And that's when you get retrograde pulpitis because of the periodontal disease. Periodontitis rarely produces significant changes in the dental pulp. Okay, severe breakdown of pulp does not occur until periodontitis has reached a terminal state. Um, so there's periodontal and endodontic lesions. Okay, retrograde pulpitis, meaning that you have uh, bone loss. You got furcation, you got mobility, and you got plaque and stuff like that. Retrograde periodontitis, that's where the periodontitis is the victim. Periodontitis caused by extension of inflammation from the gingiva, most common route of infection. It's through the apical foramen, through the lateral canals. So abscessed accessory canal. No furcation there. Patients with pulpal disease may have a healthy periodontium. Endodontic procedures are mostly caused by decay. All right. So pulpal endo versus periodontal. Occasionally, an abscess of pulpal origin will establish drainage through the periodontal ligaments. Fistula is not usually present in this case. Patient with periodontal value should be consistent with pulpal disease. If scaling an abscess, only use the scalers that can be used on that area. Okay, you don't want to transfer bacteria from one place to another. Endoperio lesion. Primary pulpal infection can lead to chronic perioradicular periodontitis. Independent periodontal versus endodontic lesions. Independent is the most common. That's what we need to know. Independent periodontal lesion is the most common. Okay, that's pretty clear right there. Apical lesions, combined lesions, it's almost like they made friends. It's like pink is buccal, is bone loss. So you got a lot of bone loss and you got infection. That's a combined lesion. Pain, and yeah, it's bad. So there we go, man. Review, review, review. We're going to do just fine with this test. Quiz. Thank you very much.